there. My name is Tabetha Ruple, and I'm the Director of Implementation and Training for Hospi Corp, the maker of the Macy Catheter. If you're here today, you're here for an IPU training to learn more about the Macy Catheter. It's a different route, but it's a better journey. I first want to start a little bit about some general information about the catheter. The FDA indication for the catheter is to provide rectal access to administer liquids and medications. You do need a physician or nurse practitioner order for use, and it can be in place for up to 28 days. It's a non-sterile placement, and an initial placement is by an RN, LPN, or LVN. The same catheter can be reinserted after a bowel movement. Now, if you have a patient that is going to be discharged home, you can teach a patient's family member or caregiver how to reinsert the Macy catheter and also how to medicate via the catheter. The one thing about the Macy catheter, it's so easy to use. It's 4 easy steps, and it takes about 3 minutes to place the catheter. You're going to lubricate to the first triangle. You're going to insert the catheter, you're going to inflate and then secure the catheter to the patient's leg or abdomen. Now I want to talk about utilizing the Macy catheter in the inpatient setting and why it's such a great tool. It's more effective than subcutaneous delivery, it's more comfortable than parenteral, and it's easier setup, maintenance, and drug disposal. All medications can be administered via one port, so you don't have to worry about rotating sites with sub-Q. It's cost-effective versus sub-Q or IV with less medication waste, so it's perfect for the IPU. I want to talk a little bit about the regulatory guidelines in CMS. We receive a lot of questions regarding whether we can utilize a Macy catheter in the IPU, and does it meet IPU standards of care. And in actuality, CMS does not dictate what mode of medication delivery is utilized in the IPU. They're only concerned with the need for 24-hour clinical management that cannot be provided in the home setting. So what does that mean for you? What that means is that it requires that a nurse is assessing and reassessing that patient as you're titrating medications. It also means that there is either a physician or a mid-level practitioner that has medical oversight over the care of the patient. Those are things that cannot happen in the home setting because you do not have a 24-hour RN care in the home caring for the patients. I also want to talk about some of the CMS regulations that they're looking at to meet. The first one is the patient areas should provide a home-like and dignified atmosphere. Well, the Macy catheter is discreet and hidden. There's no needles, pumps, or IV lines. Secondly, you must have an infection control plan minimizing infection risk. Well, with the Macy catheter, there's a decreased risk of blood-borne infections. Thirdly, the physical environment must be safe for patients, staff, and visitors. Well, in my experience, since you're not utilizing needles, you're just utilizing a soft, flexible tube, there is no risk for needle sticks for either the patient, the visitor, or staff. However, in my personal practice, I have seen where nurses have been stuck with contaminated needles with hepatitis A, B, and C. So you really want to make sure that your team is safe. And lastly, must have a disaster preparedness plan. We're able to provide hydration and medication and care for patients in place in the IPU. So you don't have to worry about supply chain and getting parenteral medications delivered to your unit. It's really quite effective. Now I want to draw your attention to the picture on the right. You'll look at the rectal vault here and you will see that the lower third is highly vascularized with a high percentage of absorptive cells. This makes for a great way to absorb medications. At the end of life, a lot of our patients are very dehydrated. They're not eating or drinking anymore. They're also on medications that cause additional drying, such as anticholinergics and opioids. When we inject medications in a liquid form, that medication is ready to transition across the mucous membrane for immediate circulation and rapid onset of palliation. With pills or suppositories, that does not occur. This is a problem because the rectal vault needs between 10 and 15 mLs of fluid to break down and absorb those medications so they can cross across the mucous membrane. So what ends up happening is the pill or suppository sits there intact. The other point to recognize is that we do not have to worry about blood flow to the rectal vault at the end of life. We know that the medications are being absorbed because there is great blood flow. And we know this because if you take a rectal temperature, you can see that it is at the normal temperature that a patient would be at. So we know that it's being well perfused. Now, with other modalities, we know that that is not the case. We know that perfusion at the subcutaneous space drops when blood pressure drops. This is evidenced by coolness of extremities and modeling of the extremities and sometimes even the abdomen. If blood flow is shunted to the core from the periphery and you're utilizing a sub-Q site, you may be delivering medication to a reservoir, and that reservoir is going to have decreased perfusion because there's decreased circulation to that area. So that's really a challenge when palliating patients at end of life. I am going to cover this a little bit more in a study that was done that I'm going to be sharing with you shortly. I want you to take a look to your left to look at all the drug classes that I have listed here. The rectal route is only second to that of the oral route when we talk about versatility. And patients, if they're able to swallow, can take all of their normal medications, and that's not an issue. However, when they're not able to swallow or they start to aspirate, it becomes a challenge when we're palliating. As you see to the right, you'll see the limitations with the sub-Q, IV, and sublingual modalities to palliate patients. And you'll find that the rectal route is most optimal. I want to talk to you a little bit about when to use the Macy catheter. First, consider it prior to any IV or subcutaneous medications. Get away from the IVs. The patients don't like getting stuck, and neither do the nurses. If a patient has a pre-existing IV, consider switching to the Macy catheter when there are severe symptoms that are poorly controlled. Also, if you have medications that you're treating multiple symptoms or there's large volumes of medications that you're administering, this is a time to think about the Macy catheter. And then lastly, as I stated before, if you're considering sending a patient home and you're looking for a discharge plan, transition to the Macy catheter. It makes for a great discharge plan. Now let's talk about rectal hydration. It's not often that we hydrate our patients at end of life, but there are some situations where it's necessitated. If you have a patient that has intractable nausea and vomiting and they're very dehydrated, that may be a great time to initiate hydration. There are also some other situations that may be considered, such as psychosocial reasons or religious reasons in which hydration should be considered. Now, as you see in the picture here, we have a patient that is positioned on their left-hand side. We're going to infuse boluses of just hypotonic fluids, either plain tap water or Pedialyte. You can give boluses up to 250 mLs in 1 hour, spaced a few hours apart. It's quick absorption because as the patient is laying on their left-hand side, you'll see that the rectal vault is elevated so that when fluids are entering the rectal vault, it drops down into the descending colon. The descending colon is meant to absorb fluids. So it's very rapidly going to absorb that fluid on the bed of that colon. And within 30 minutes of completion of the fluid bolus. You can have the patient remain on their left-hand side just so the rest of that fluid gets absorbed. And then after 30 minutes, you can position your patient for comfort, either on their back or on their right-hand side. It's very effective. Now I'd like to talk about clinical effectiveness and comfort evidence that was assessed via Ohio's hospice. They did a survey of their nurses, and I'm going to share that information with you. It's quite compelling. Just to give you a little overview on Ohio's hospice, it's several different locations: Dayton, Lifecare, Central Ohio, and Miami County. They've utilized the catheter on over 3,000 patients last year, and they performed this survey of nurses comparing the Macy catheter to sublingual and sub-Q, looking particularly at comfort and effectiveness. The results are now going to be published in the December 2020 issue of the Journal of Oncology Nursing. So if you're interested, keep an eye out for that. We're first going to take a look at subcutaneous versus the Macy catheter. If you look to the left, you'll see that there was a question regarding comfort. 82% of the nurses that were surveyed stated that the Macy catheter was more comfortable than sub-Q, with an additional 15% saying that was equally as comfortable as sub-Q as the Macy catheter. So you have a total of 97% of the nurses saying that the Macy catheter was equally, if not more, comfortable than the sub-Q site. And then when we look at effectiveness, 52% of the nurses said that the Macy catheter was more effective than sub-Q. An additional 40% said it was equally as effective as sub-Q. So you have a total of 92% of the nurses saying that the Macy catheter was equally, if not more, effective than the subcutaneous route. This was a question that came up, and I feel that it's very important. They asked the nurses if they were asked the question whether the Macy catheter was effective in treating severe symptoms. The question was as follows: in my experience, if I was asked by a family member or friend who had a family member in hospice whether they should consider the Macy catheter for symptom management of the hospice patients, I would say, and 97.4% of them said that the Macy catheter works for severe symptom management. Now think about that, the most severe symptoms. That's quite compelling. Now when looking at sublingual versus the Macy catheter, this is very interesting. 70% of the nurses surveyed said that the Macy catheter was more comfortable for patients than sublingual, with an additional 26% saying it was equally as comfortable for the patient as sublingual. So that is 96% of the nurses saying, as far as comfort, the Macy catheter was as comfortable, if not more comfortable, than sublingual. Now moving on to effectiveness, 78% of the nurses said that the Macy catheter was more effective than the sublingual medications, with an additional 21% of the nurses saying that the medications were equally as effective. So you have a total of 99% of the nurses saying it was equally, if not more, effective than sublingual. Now that you have a broad overview of micro-enemas and the quality and effectiveness, we're going to get into what the Macy catheter looks like and how it works so well. So first, you're going to see the medication administration port. This can be accessed utilizing an enteral or oral tip syringe. Secondly, you're going to see the balloon inflation port, which is accessed utilizing a Luer-Lock syringe. You're then going to see the two placement markers that help guide the practitioner to place the catheter. You'll see the balloon here, which is instilled with 15 mLs of just plain tap water, and that's about the size of a quarter. You're going to see the medication delivery holes. There are two anteriorly and two posteriorly. Now we're going to move on to the Macy Catheter Bedside Care Kit. This has everything you need for the insertion and medication administration for your patients. You'll see that there is a small instructions for use pamphlet, and that is for clinicians. And then you'll see one that's in larger print, and that is for patients and family members. If English is not their primary language, there is a pictorial step-by-step that will guide them so that they will know what to do. And then lastly here, you'll see instructions and medication sheets. The medication sheets may be utilized by the patient's families as a guide when to medicate the patient. Next, we have the medication preparation setup, which is the Liquipill system. And then we have the insertion of the catheter section, where we have the Macy catheter itself here, the Luer lock syringe, gloves, water-soluble lubricant, and we also have a securement device that can be utilized either for the leg or the abdomen. So prior to insertion, we're going to assess for stool. It's best if the rectal vault is empty, but it's not necessary to have it empty. If there are some formed stool in there, it's not a contraindication for use. However, if a patient is impacted with stool, please follow your organization's policy and procedure regarding disimpaction. And then we're going to assess for contraindications. We're going to look for any rectal lesions, tumors, any active rectal bleeding, recent bowel surgery within 6 weeks, or any compromised rectal mucosa. Now I'm going to have Morgan share with you how to insert the Macy catheter.
Inserting the catheter is much like inserting a urinary catheter, only easier, faster, and is a non-sterile technique. Insertion usually takes 3 minutes or less. First, lubricate the distal end of the catheter to the first arrow. Second, positioning the patient on the side or in supine position with knees bent, insert the catheter to the line between the 2 arrows. Third, remove the red safety cap and inflate the balloon to 15 ml using 15 ml of room temperature or cool tap water. Fourth, tug gently to assure the catheter is snug against the inner portion of the rectal sphincter. Finally, secure the catheter by running it between the patient's legs and securing to the thigh or lower abdomen. Administering medications through the Macy catheter is a simple 3-step procedure: draw, inject, and quick flush. If medications are already in liquid form, they can simply be drawn up using the 10 ml enteral syringe provided in the kit and administered via the medication administration port. Medication should be administered over 3 to 5 seconds. 1, 2, 3, 4, 5. Some kits contain another Hospi product, the Liquipill system, to help prepare medication suspensions. Once medications have been administered, please follow with a 3 ml quick flush of tap water. This quick flush should be administered in less than 1 second. 1. If the catheter is not properly quick flushed, on rare occasion there may be leakage from the medication administration port. To solve this, please inject another 3 ml using the 3 ml enteral syringe of tap water and inject over less than 1 second. 1. This should correct the situation. That's all there is to Macy catheter insertion and medication administration. For more information, please visit macycatheter.com. Thank you so much for your time.
We're going to move on to the Liquipill components, and I wanted to show you just a quick pictorial regarding the grinding system. It's very much like a pepper mill, and Brad thought of all different age groups when thinking about how we're going to crush medications so that we can liquefy them. It's ergonomic so that people of all ages can utilize it. You'll notice also that there's a syringe adapter cap for the medication receptacle, and then there's a water receptacle and a syringe adapter cap as well. We're going to have Morgan show you again how to utilize the Liquipill system.
Taking the tablet that you would like to crush, you simply put it in one of the two slotted openings. Second, simply move the grinder back and forth like a pepper mill to crush the medication into a fine powder. The grinder is very easy to move back and forth and was designed with caregivers of all ages in mind. You will know the medication is completely ground because the grinder gets smooth and quiet. And as you can see here, the medication has been ground into a really fine powder. So now you're ready to add a little bit of water. Taking your 10 ml enteral syringe, you'll put it on top of the syringe adapter cap. I just put in room temperature tap water into this water receptacle. I'm going to pull back 10 mLs of the tap water and simply put it on top of the medication reservoir and inject. Next, I'll just swish and swirl for about 10 seconds. This makes sure that the medication is fully in suspension form as you get ready to give it via the Macy catheter. So next, you'll draw up the 10 ml suspension, and you're ready to administer via the Macy catheter. It is important to note that you will want to have a 3 ml quick flush to follow that to make sure that all the medication gets through the Macy catheter.
We're going to go through care and troubleshooting of the Macy catheter. So as far as peri-care, it's going to be just regular routine peri-care as you normally would do. It can be utilized and performed with the Macy catheter in place, regular soap and water. As Morgan stated, if there's leakage from the medication administration port, if it occurs, you're going to draw up 3 mLs of water and you are going to instill it very rapidly over 1 second to clear. Typically that occurs because there's some particulate matter in the valve. Any leakage from the rectum, what you would do is you're going to check the balloon positioning and you're going to also check to make sure that there's a full 15 mLs of water in the balloon. You deflate the balloon, reposition, and reinflate with 15 mLs of just regular tap water. Now, if a patient has poor sphincter tone, you can add more water. You can add between 2 to 5 cc's, and you're just going to wait and just gently pull back to make sure that there's a good seal. You can go up to 30 mLs of water if need be, but in my experience, I have not had to do that, but it's good to know. Next, I'd like to share with you some information from Ohio's hospice. They're going to be sharing with you their experiences in their IPU with the Macy catheter.
One of the big things that we've been facing recently are the national drug shortages, especially of all the injectable opioids. So when we were faced with that challenge, one of the routes that came up was using the rectal route. And of course, anytime you talk about the rectal route, there's an understandably reluctance to want to use it. It's an invasion of privacy. Any medication that's given the rectal route has to be done so repeatedly, so it's a repeated invasion of privacy. Suppositories are not comfortable to give. They can cause trauma, and they have to be given correctly.
The Macy catheter offers a comfortable and discreet way to administer medications while still maintaining the dignity of the patient by allowing medications to be given without repositioning the patient or repeatedly invading the patient's privacy.
Because of the national shortage, we didn't have many options, so that's when we really started to investigate the Macy catheter more thoroughly. And at which point, like our injectable usage, we were not going to be able to sustain that. That's when we brought the Macy catheter folks in and learned about it and gave it a shot. And from there, it's been amazing.
We function on the level of a hospital here. And I didn't realize there was something better than what we were already using. This is a whole new level of practice, and I will never go back to the practice that I had before. And I just cannot emphasize enough. I can get people comfortable. I can keep people comfortable. I'm not accelerating medicine. I'm not adding medicine. You get the Macy in, you give them medicine, they're comfortable, and that's it. Less cost, less waste, not having to poke them, not having to maintain a peripheral IV, not having to use subcutaneous injections. You put in the Macy, you have excellent absorption, you have excellent patient comfort.
We now have a tool that we can pull out, we can insert, we can give medications without having to stick people. Families and patients don't like needles. And this is not a needle, and it's very comfortable. I haven't had any patient that seemed like it's disturbed them at all. Most of the time they don't seem to even notice that we've put it in.
Even the nurses that were the holdouts. I talked with one nurse this week just preparing for this conversation and said, hey, tell me what your thoughts are. She says, I wanted to hate it. I didn't want to like it, and I love it. And I mean, the nurses are on board.
This is a catheter I would use with my own family. I would put this in my mom without a second thought.
Let's review again, one last time, when to utilize the Macy catheter in the IPU. So first off, as a first option for severe symptom management, consider it prior to IV or subcutaneous medications. If a patient has a pre-existing IV, consider switching to the Macy catheter when you have symptoms that are poorly controlled or you have multiple medications or large volumes and symptom control is necessary. You also want to consider switching to a Macy catheter if you are looking to send a patient home and you want them to maintain that palliation that they had in the IPU, so transitioning them to a Macy catheter. Consider the Macy catheter as a first option, not the last resort. I do want to share with you some resources that we have for you. The first one is the Macy Catheter Community Facebook page. So you can go on to Facebook and join other practitioners that are sharing information regarding their experiences with the Macy catheter. We also have a website, macycatheter.com, and on there you're going to find information in the clinical corner. We have research papers, and we also have what we call Macy moments that nurses share their experiences regarding utilizing the Macy catheter in their practice. We have monthly live clinical training webinars, and it's every third Thursday at 2 p.m. Eastern Standard Time. And then we also have a thought leader series that we put on typically once every quarter. And we do have many of those recorded webinars that are on there so that you can watch on demand. Most recently, we did do an IPU webinar that you may like to watch. So as far as ongoing clinical support, we do have a 24-hour clinical line. So if you want to take out your phones right now and punch in this number, 1-888-509-3732. Our extension for clinical is extension 2. So 24 hours a day, 7 days a week, 365 days a year. If you have a problem, a concern, or a question, please reach out and contact us. If you have a non-urgent issue that you would like to be addressed, you can email us at clinical@hospicorp.com. Or, as I said before, if you want to look at some of our resources and navigate around our website, we have training videos there, publications, blog posts, and more. So please feel free to do that. I'd like to thank everyone today for joining us. Thank you and have a great day.